Good morning. This is Dr. Hendrada. I'm here today with Dr. Alex Mangarian. This is our bipolar series. Today, we are going to talk about the effect of sleep deprivation and precipitation of mania. We had two more recordings before this that were laid the general understanding about bipolar disorder. Moving forward, we'll go into depth the neurobiology of mania, and then we're going to talk about the neurobiology of bipolar depression. We're going to talk about cyclothymia. We will talk about insulin resistance. We are going to talk about leptin resistance. And if need be, we will talk about the treatment. Uh, so before we do all those things, let's talk about how sleep affects bipolar disorder. So if we look at the risk factors for bipolar disorder, right? So one of the most important risk factor for bipolar disorder is sleep deprivation. This is the number one risk factor. Sleep deprivation is also considered to be a prodrome for mania, right? Sleep deprivation will be present before a mania is precipitated. So if a patient basically has an increase in the sleep onset latency, that means that they are taking a long time to fall asleep, or they have a decrease in the duration of sleep. Now, these two are very important risk factor for the precipitation of a manic episode. The prevalence rate is approximately 70 to 77%, right? So even when they look at the EEG in patients with mania, the things that they see is there is an increase in the sleep onset latency. There is variation in the duration on the quality of the sleep depending upon whether they are in the manic or in the depressive episode. There is a decrease in the slow wave sleep. This is the restorative sleep where you usually have memory consolidation. And there is an increase in the REM sleep density in patients with bipolar mania, right? When there is sleep deprivation, the risk actually is 4 times for precipitation or relapse into a bipolar manic episode. The second risk factor for relapse in patients who have bipolar disorder, who are on mood stabilizers, is presence of residual symptoms, right? That means that you have treated the bipolar disorder, but there are still some residual symptoms. That usually increases the risk of a relapse by about 3 times. Third risk factor is sudden discontinuation of the medication, right? So the medication could be lithium, it could be an atypical antipsychotic, it could be other mood stabilizers like sodium valproate, right? But just remember, we don't use sodium valproate in patients in the reproductive age group, both men and women, all right? So be careful with that. And here the risk of sudden discontinuation of the medication is about twice actually the risk of precipitation of or relapse of a manic symptoms. Other risk factors are presence of anxiety disorder. I'm talking about comorbid anxiety with bipolar disorder, young age of onset of bipolar disorder, and increase in the number of episodes, right? So these are other risk factors for relapse in patients with bipolar disorder. So today's episode, we are going to talk about how sleep deprivation precipitates mania. So let's talk about sleep deprivation, right? So few things that we are going to talk about today is the role of adenosine in precipitation of mania. Second is the role of dopamine and other neurotransmitters in bipolar mania with sleep deprivation. And the third thing that we are going to talk about is the HPA axis. There are other literatures which also talks about neuroinflammation with sleep deprivation. But when I looked at it, the data was not too strong. It was mixed results, especially they're talking about the involvement of microglial system, right? But we are going to focus on the first three topics. So let's look. Now, before we do that, I would like to actually talk about a case. This is a case of postpartum precipitation of mania due to sleep deprivation. So let's talk about a clinical case scenario. This is pretty common. You guys will encounter this case during your practice, in your residency as well as post-residency. So this is a case of a 30-year-old woman with a known history of bipolar 1 disorder, currently euthymic, on lithium monotherapy. Delivers her first child via prolonged 22-hour labor. During labor and first 48 hours postpartum, she loses at least one full night of sleep. Over the next 3 to 5 days, she's breastfeeding every 2 to 3 hours, sleeping only 2 to 3 hours per night in fragmented intervals. By postpartum day 4, her partner notices she's unusually talkative, euphoric, making grandiose plans to start a business, and appears to have no desire to sleep. By day 6, she is frankly manic with psychotic features, believing she has a special spiritual connection with the baby and requires psychiatric hospitalization. You will encounter this case, and I selected a patient who is postpartum because this also gives us an opportunity to talk about postpartum relapse of bipolar disorder, especially a manic or hypomanic episode. And even ACOG also recognizes postpartum period as a very high risk for precipitation of bipolar mania or hypomania in patients with history of bipolar 1 disorder or who have risk factors for bipolar disorder. Perfect. So now let's talk about this particular case. So what is going on, right? So postpartum period, so first is labor. Labor itself actually causes sleep deprivation, right? Then after the labor is done and the baby is born, then there is other periods of sleep deprivation because now the mother has to wake up every 2 to 3 hours to feed the baby. So the mother is sleeping during the daytime with the blinds on, right? So your 24-hour circadian rhythm is disrupted. Then the mother has to wake up multiple times in the middle of the night, turn on the light to breastfeed the baby, and light itself can actually disrupt the sleep wake cycle. Plus, waking up multiple times in the middle of the night disrupts your entire sleep wake cycle, especially the rhythm between non-REM and REM sleep. And as we know, the slow wave sleep, that is a non-REM sleep, is usually seen during the first 90 minutes, right? And then you usually have the REM sleep. So when your architecture is disturbed, you have decrease in the quality as well as the duration of the sleep, right? So your entire circadian rhythm is completely disturbed. And there is data that 24 hours of sleep deprivation in a patient with bipolar disorder increases the risk of mania by 2 times, right? So now let's see what exactly is happening. So when we are awake for a long period of time during our 24-hour cycle, right, there is buildup of adenosine, right? And this adenosine is responsible for the homeostatic drive, right? So as the adenosine builds up, by the end of the day, this buildup of the adenosine will inhibit the wake promoting areas of the brain. And this precipitates, or this makes us fall asleep. And also adenosine is responsible for increasing the slow wave sleep, which is the restorative sleep required for memory consolidation and a restful sleep, right? So what is happening in patients with bipolar disorder, right? In patients with bipolar disorder, there is a problem, especially in the purinergic system, right? Purinergic system, adenosine is a part of the purinergic system. So there's a problem in this particular system, right? It's not that there is a problem, especially in the production of adenosine, right? But what they found out was that in patients who are in a manic episode, there's an increase in the plasma uric acid level. right? And uric acid is a byproduct of adenosine metabolism. I'm not going to go through the steps. You can actually find out the step. The final pathway actually is involving xanthine oxidase, right? So the question is there an increase in the activity of xanthine oxidase? I tried to actually find literatures on it, but that is not true. So there is no increase in the activity of xanthine oxidase. The only thing that we see is that there's an increased metabolism of adenosine, and that is why there is an increase in the uric acid level in patients with bipolar mania, right? Plenty of literatures on this. So what they found is that allopurinol, which is used in patients with gout, inhibits xanthine oxidase and thus increases the adenosine level and can help in the treatment of mania, right? The literature is the effect size is small to medium. So what happens is that the byproducts of adenosine metabolism before the xanthine oxidase can be reconverted back into adenosine, and that is how allopurinol works, all right? So now we know that there's a problem, especially in the purinergic system, that is adenosine, right? Which is actually broken down, and there's an increase in the amount of uric acid in patients with mania. Adenosine, basically in a healthy individual, works on two different receptors. Adenosine A1 receptors, which is present in your sleep center. And when adenosine acts on A1 receptor, it inhibits the wake promoting areas of the brain, right? There is no problem in the number of A1 receptors, right? But the functioning is reduced because we don't have enough adenosine available to hit these receptors. And that basically what it does is that your wake promoting agents are not, wake promoting regions of the brain are not inhibited. So you are in a constant hyperarousal or wakeful state. So we talked about adenosine A1 receptors. So there is no problem with this A1 receptor density, but its functioning is reduced because of the problem with the purinergic system, that is the adenosine, right? Adenosine also, so this leads to a constant state of arousal or wakefulness. Adenosine also acts on the A2 adenosine receptors. Now, this is interesting. The A2 adenosine receptor forms an heteromer with the D2 receptors, that is D2 dopamine receptors, in your striatum, right? That is the basal ganglia. So what happens is that the A2 adenosine receptor is coupled with G stimulatory protein, and the D2 receptors are coupled with GI or G inhibitory protein, right? So G stimulatory will stimulate the cyclic AMP, that is adenosyl the cyclic. So GS stimulation will increase the cyclic AMP, whereas D2 stimulation will inhibit cyclic AMP, right? So when adenosine acts on the A2 receptors, that will inhibit the activity of the D2 receptors, right? So as we know, this particular heteroreceptor is present in the indirect pathway in the basal ganglia. I want you guys to look up indirect pathway. So the indirect pathway goes from the striatum. So these are D2 medium spiny neurons. These are inhibitory GABA neurons, right? So they are rich in A2, D2 heteroreceptors. So when these D2 medium spiny neurons are activated, they can inhibit the globus pallidus externa, which is again GABAergic. So when you inhibit it, it is not able to inhibit the subthalamic nucleus, which is glutaminergic in nature. If you do not inhibit subthalamic nucleus, since it's glutaminergic, it will stimulate the globus pallidus interna, substantia nigra, pars reticulata. These are GABAergic in nature. And this will then inhibit the thalamus And this in turn inhibits your motor cortex, right? So you can actually decrease the psychomotor activity. Right? Plus, this also involves the reward system, right? In the nucleus accumbens, what it does is that it decreases the reward-seeking behavior. Right? This is how the indirect pathway works. So adenosine, if it actually hits this A2 receptors, then what happens is that it will block the D2 receptors. And as we said, the adenosine A2 receptor is coupled with G stimulatory protein, right? So it can stimulate the adenylate cyclase pathway. So what happens when you stimulate it? It will inhibit the globus pallidus externa. So this entire pathway gets activated. And this can actually lead to decrease in the psychomotor activity and decrease in the reward-seeking behavior, right? Makes sense. So what happens if the purinergic system is not functioning well? This whole system of the indirect pathway is disrupted, right? So what happens? If the A2 is not stimulated, you cannot block D2 receptors. If you do not block the D2 receptor, then what happens? This inhibition is gone. So this will inhibit the subthalamic nucleus now, right? If you inhibit the subthalamic nucleus, what happens? This subthalamic nucleus is not able to stimulate globus pallidus interna, substantia nigra pars reticulata. This cannot inhibit the thalamus. This cannot inhibit the motor system. So what happens? Then you will basically have increase in the psychomotor activity, as well as you'll have increase in the reward-seeking behavior, because here the nucleus accumbens is involved. And you can see an increase in the psychomotor activity as well as increased reward-seeking behavior in patients who are manic, right? So there is an A2A receptor antagonist, which is called istradifylline, which is used in treatment of Parkinson's disease, right? So when you give A2 antagonists like istradifylline, it's the same mechanism, right? You basically increase the psychomotor activity, and that is what you need in patients with Parkinson's disease who have a lot of bradykinesia. They don't have enough psychomotor activity, right? They freeze. At the same time, istradifylline can also precipitate a manic episode.